So thank you very much for the invitation. We will talk today about the wire rupture. I don't know. Maybe I have to click here. Okay. So the rupture of a wire is often considered a benign complication. If you go to experts meeting, especially at CTO meetings, everybody will say, Chadem, the wire broke. So leave it there. It never provoke a more severe complication. We can leave it there. And every expert recommends currently a conservative approach. But it is really so? Let's see. We are going to see first 3 cases and then some results from a bench test. This is a 62 years old female lady with hypertension, angina, class 2, which currently would be a debatable indication for percutaneous revascularization. So we decided the therapeutic strategy of treating the right coronary artery and then FFR of the proximal LAD stage. This is the PCI of the right coronary artery, clear, positive RFR, so no need to inject adenosine. It was vascularized, and then the operator decided to treat the proximal LAD and place the second wire in the circumflex just to protect it because we are very close to the left main. During removal of this wire in the circumflex, which is minimally overstented, we observe a wire rupture. The operator pulls the wire and the wire still appears on the screen, so that means that the wire is ruptured. He asks for help, he calls me, and we remove the wire with a snare, and everybody's happy. The angiography looks perfect. So, and this is the picture of the wire that we removed with the snare. I bet most of us would stop here, right? And actually it's a very good result. Everybody could be happy. I see. So we decided to do a mini culotte because of the possibility. It was clear that we had stented the left main, and the result was a little bit. And I was not totally happy because in the angio, if you look, you see some kind of loop there in the angio, which was not present at the beginning. So we did OCT just to understand what that loop was and see what we are watching there. This is what this loop was. This. I bet these images that we see there, that we call it the Olympic rings sign, are this braiding around the wire, which was spread and left there at the left main. We call it the Olympic rings sign, and these images probably are the braiding that is around the wire, which is hardly could be hardly seen in the angiography, but which is clear here at the OCT. So this is the mesh that we can see if we do a 3D reconstruction. And we are actually in the proximal LAD and in the left main. So what the question now is, do we leave the metallic braiding debris like this? Yes, they will be rendothelialized like the stent. This is what most of the experts would answer. I would remove them if I knew how. I don't know how we can remove it percutaneously. 3, call the surgeon, which is a bit aggressive, and let's do imaging. Imaging, if you get a quiz like this, and one of the answers is imaging is always the right answer, or at least the answer that the presenter wants you to answer. But we have already done imaging, so I put it here, but we have already done imaging. So what would be your approach? How many of you would leave it like that, and let's see if they get rendothelialized?
Maybe second stent.
Second stent? That's another option. We would increase the metal to artery ratio, but probably we would diminish the prolapse of this metal. This is another option. Okay, let's see what we did. We decided to follow most of the experts' recommendation to be conservative and to rely on Mother Nature to reendothelialize that metallic debris. So 3 months later, the lady comes back with left main thrombosis. We could do the angio, but immediately after this injection, the left main got occluded. We could not advance. We could not advance the wire. Even with aggressive wires, we have problems to go through this metallic mesh that we have seen in the previous intervention. And actually, the left main was occluded. The lady fell in cardiogenic shock, had to be put on ECLS, and underwent emergency CABG. Unfortunately, the myocardium could not recover and she died 1 week later after active cardiocirculatory support. So we were a bit shocked because we could have avoided. We could have avoided this if we knew the relevance of this apparently minor complication that we have. So this made us think in 2 months later, so in a relatively short period, we had a second case. This is a 72-year-old male who is a relative of one of the nurses in the cath lab. This explains a little bit the different approach. And this nurse was present in one of the interventions of the previous lady. We see here this left main stenosis, and the patient refused surgery. So we decided to revascularize the case percutaneously. Apparently, it's not a complex intervention. We protect the circumflex, we implant the stent. These are the wires. And when we have ended the intervention, we see there, trapped in the plaque, like a metallic tip. I don't know. You cannot see my pointer, but you see the tip trapped in the previous plaque of the stent. So, since we had the experience of the previous lady, let's do OCT. If we see the Olympic rings again, maybe we will be more aggressive this time, and we will do a more active role in the revascularization. But the OCT could not cross. We have removed the wires, as you can see. We tried to rewire. The wire went through the mesh, but the OCT could not cross actively. So this was quite discouraging. So we decided, okay, let's do something else. Let's do a CT. And you can track the spread braiding of the wire up to the subclavia. So we discussed that. The nurse was there, who was a witness of the events with the previous lady. So we recommended surgical extraction and revascularization, just to avoid another catastrophic result like the previous one. And the patient is doing well. He has come after that and has no problem. But it seems to be quite aggressive approach just for a wire rupture, but we had the previous experience. So finally, we have a third case, which is a 62-year-old male with cardiovascular risk factors, previous STEMI, treated with an stent, and now with severe angina and decompensated heart failure. So we have this angiography. We decided to go stage to do an RFR revascularization. So we started by the LAD and the diagonal. This was treated, guided by RFR, just until we got a result. And this was the last shot we did before removing the wire. So we stopped at this point. They said, okay, we will complete the revascularization of the right coronary artery in a second stage. The patient comes back. I guess this is, okay. Comes back 2 months later, just to complete the revascularization. And in the first shot we see the wire in the LAD. Probably the operator had removed the catheter, expecting that the wire would come back with the guiding catheter, but the wire, then FFR wire, the iris, was left there in the LAD. 2 months later. Okay, since we are a bit sensitive about the topic, we decided to do OCT. Well, I anticipated that. Okay, what to do? Conservative approach, leave the wire in the LED, it will be endothelialized, remove the wire, call the surgeon, or imaging. And as I told, every time imaging appears is the right answer. So we decided to do OCT. Let's see what we see, because it's very interesting. We are starting at the LED. The stent is well endothelialized, and you start to see there the wire, which is partially endothelialized. You can see it. So the endothelium is trying to cover the wire, but sometimes it's just in the middle of the vessel. And this is the typical shape of the FFR wire. And very important, we don't have this spread debris at the left main. So it's a totally different scenario. Still, when you have this scenario, just to come here and say, well, even though it looks nice, sometimes it creates problems. This is the 3D reconstruction, and you can see, you can track the wire quite far, but it comes a point where the wire stops, and then we don't have this spread debris that we saw in the previous cases. Still, this is the distal tip of the wire. Here, as you can see, it's partially endothelialized. You can see some breaches of endothelium trying to cover the wire. Here it looks, this endothelium looks rather like a clot, a bit irregular, and probably because the wire is not so fixed like the stent is. You can see here as if the endothelium had tried to cover the wire, and the wire has escaped that cage that the nature was trying to create for her. Here it's even more clear. I bet the wire was here, and due to the movement, it has escaped that cage. But very important, in the proximal LED, this is the bifurcation with the circumflex, and in the left main, we don't have any foreign material. Still, in this scenario, it was very easy to extract the wire with a snare, and then we did it. And it's very nice to see the pre-post images. I tried to match them, and this is the wire completely endothelialized, leaving here now like a spot, and this image with apparent thrombotic or with a clot here disappears completely in this other setting. This wire, which was partially covered with the shadow, leaves now a very, very tiny dot there. And these places where the wire was covered is now in this C shape. Okay, the same here. This is very nice because you can easily recognize the same structure pre and post. And this cage is now left alone with the wire which escaped to that one. So, trying to understand this and trying to make like a more general recommendation, 3 medical students of the university in Madrid came to the hospital, and we did like a bench test. This is the bench test, which is a test of resistance to rotational stress, to torsion. And the endpoint is registering what is the point of rupture. At some point you feel like some vibration, and you feel that the tension of the wire is not the same. So the core of the wire has broken, and continuing until we register the point of discontinuity, until we see that the wire is disconnected. One tip, one extreme of the wire is disconnected from the other one. And after the point of rupture, we submitted the wires to 2 different stresses. Continued torsion, to see if we can break the wire completely, or stretching, pulling, which is what we usually do when we experience the rupture of the wire. We pull from the wire. Let's see what happens. And then we register whether we see a clean rupture or this break spreading that we have seen in the images. This is more the bench more in detail. We have a fixing gear with the tip of the wire at this point, and we have the microscope very close. And then we have the rotating gear with some marks. You see a green mark there just to measure how many turns we are doing and we are submitting. And we always systematically, because we could come to different results, systematically the distance between one gear and the other are 90 centimeters. So this is one example. This is then FFR wire, because the rotation is easier to see than in other wires. I just chose this one. This is what we are registering with the microscope. Here you see an example of clean rupture, where both ends are totally detached from one another. And here you see an example of braid spreading. This is the tip of the wire, and this is the core of the wire, but around the one and the other, you see this braiding that is usually around the wire, and once you break it, it is spread all around. And this braiding, according to our view, is responsible for the problems that we have seen in the clinical cases. So, these are the turns of all the wires that we submitted to this test, and you can see that it's very irregular number of turns that each wire breaks. Even using the same wire, you see very large differences. So we don't come to any conclusion. Is there a wire more resistant to torsion than another one? It's difficult to say. But we have still interesting results. 6 of the wires, just at the point of rupture, they break completely. So they have a clean rupture in approximately 28.6 of the wires. These wires are, this phenomenon is only seen in BMW, BHW, or in Gaia third. So all 6 cases happen in these 3 wires, which is something that would be worth to explore. And more importantly, at the point you notice that the wire is broken, this is interesting for CTO retrograde approach, at that point you never have braid spreading yet. So we still can do something. We can decide how to proceed to avoid the catastrophe. If we stretch the wire, if we pull the wire, which would be our natural reaction when that happens, then we will have always braid spreading. That's the mechanism. When we pull from the wire, when we pull from this braiding, it's when the braiding spreads. On the contrary, if we continue the torsion, we obtain a clean rupture in 7 out of 8 wires that were submitted to that phenomenon. Only one of the Sion blue, this one, after 100 turns, we could not have detached or completely broken the wire, so we decided to pull after 100 turns, and then we have braid spreading. But I think it's a powerful message. If we pull from the wire, then is when we have the braid spreading, and if we cannot remove it on a different way, if we have decided to leave the wire there, and it's sometimes it's the only option when it happens on a retrograde approach in a CTO or in some other scenarios, probably the best approach would be continuing the torsion just to provoke a clean rupture, which is probably more benign result than the other one. So, as conclusion, the broken wires are not inert and benign, as we are told in many experts' meetings. And probably the problem is the braid spreading, because it can be prothrombogenic, as we saw in one of the cases, and more importantly, trap the devices after we rewire in successive interventions. The braid spreading always happens after stretching. So, if we feel that our wire is broken and we want to leave it there, probably the most sensitive approach would be continuing the torsion instead of stretching, just to end up in a clean rupture. Finally, an OCT-guided removal can be instrumental if we are in a scenario where this possibility is feasible. Thank you very much for your attention.